So that's our first entity, Kikuchi Fujimoto disease. Done. Okay, the next entity. In the next entity, you know, I think I have to tell you the name, autoimmune lymphoproliferative syndrome. I'm sure you have heard of it, autoimmune lymphoproliferative syndrome, in primary immunodeficiency disorder, in the immunology topic, in general pathology, in the immunology, you will see primary immunodeficiency disorder. So to explain this, I think definitely we will discuss the T cell development and all in separate classes, B cell development, T cell development. I will just give you a gist, right? In bone marrow, the T cells, right? B cell develop in bone marrow, but T cells, they migrate to thymus, that you know, right? That's why thymus is the primary lymphoid organ, right? Thymus and bone marrow. And in thymus, you know, the T cells, whatever thymus has, initially they are double negative. Very, very important. Double negative. Double negative in the sense they are CD4 negative as well as CD8 negative, right? They are double negative. Even they don't have a T cell receptor, right? Now, what happens in this thymus? In thymus, you know, they will be exposed to many antigens and all, and very selection will occur. I mean, whether it's actually it is reliable T cell or not. That's why we do positive selection and negative selection in thymus, right? Training occurs. Now after that, you know, these T cells will become double positive T cells. See, double positive T cells, CD4, CD8, right? If they are reliable. If they are not, they will be eliminated. Eliminated in the sense they will undergo apoptosis, right? Now how they will undergo apoptosis? Something should be there, na, to take them into apoptosis, right? If you have read the apoptotic pathway in detail, the intrinsic and extrinsic pathway, right? Then you will understand that in the extrinsic pathway of apoptosis, we have first ligand pathway, isn't it? It is there, right? In extrinsic pathway of apoptosis. So this first ligand will help in apoptosis of those cells, right, which are self-reactive. That should be clear, right? Okay. Now, you know what? In this disease, autoimmune lymphoproliferative syndrome, what happens? This pathway is defective. Done, right? So even self-reactive T cells are persisting. But which self-reactive T cells? Double positive or double negative? You tell me. After double negative, before becoming double positive, they are eliminated, right? Now, if this pathway is defective, don't you think double negative T cells, right, cannot become double positive, and they will persist? They will increase, they will increase, they will increase. And that's what happened in autoimmune lymphoproliferative syndrome. There is proliferation of double negative. The subform also they use DNT cells, double negative T cells, right? Double negative T cells, right? So actually, in T cell, if you know the T cell receptor, they can be majority. I mean, 90% of the time the receptors are alpha beta type, right? And whereas 5% is gamma delta. So out of these 95% normal T cells, right, you will get double negative T cells in autoimmune lymphoproliferative syndrome, right? And sometimes they also acquire CD8 phenotype later on, and because of CD8 cytotoxicity and other symptoms will happen, that I will tell you. But what you need to remember, the main pathology of ALPS is defective apoptosis, because there is defect in Fas ligand. And once there is a defect of Fas ligand, there is persistence of double negative T cells. They even can, in the peripheral blood, you can do a flow cytometry and you can see the same. You see, among the T cell receptor alpha beta type, which is the normal T cell, you have a predominant population which is CD4 and CD8 negative, right? This population, right? It's a WHO picture only. They can give you this picture, right? Then and there, you should think about this diagnosis: autoimmune lymphoproliferative syndrome, right? Not just Fas ligand, even apart from Fas ligand, even Cas10, not Cas10 mutation, even that also impairs apoptosis, right? Impairs apoptosis of whom? Apoptosis of self-reacting T cells. So if apoptosis is not occurring, they will persist. So double negative T cells will persist, right? Even there is a cutoff. If you see the criteria, I think I have, yeah. Even if you see the criteria, what is the cutoff? The double negative T cells should be more than 1.5% of the total, right? That's the cutoff. Or if you are talking about CD3 lymphocyte, it should be more than 2.5%. Again, this cutoffs can come. Definitely it can come, right? Be prepared, right? Because they are used nowadays, this cutoff. This is a WHO essential criteria, man. You cannot forget that. You cannot afford to forget that. This cutoff of more than 1.5% or more than 2.5%. If it is confusing, definitely they will give you, right? So that's it. And you know what? This condition, what I was trying to tell you is that there is persistence of double negative T cells. But you know what? What is the clinical features? The clinical feature is there is childhood onset, of course, and childhood onset lymphadenopathy, hepatosplenomegaly, cytopenia. You tell me, if you in a child you are getting lymphadenopathy, hepatosplenomegaly, cytopenia, don't you think you will think of leukemia, acute leukemia? You will, right? You will definitely think of ALL. It should be your DD, right? Because of cytopenia, you can have cytopenia, splenomegaly, lymphadenopathy, everything can there be in ALL, right? So, but in ALPS, autoimmune lymphoproliferative disorder, here, it's just the double negative T cells which are predominant, and they have and eventually they will also have other autoimmune manifestations in CNS, in GIT, right? And the cutoff also I told you, right? And the biopsy, if you see the biopsy, definitely see biopsy, anything you can do, but this flow cytometry is the gold standard here. Especially, you cannot replace flow cytometry with biopsy. Flow cytometry is the gold standard to diagnose this autoimmune lymphoproliferative syndrome. Of course, in biopsy, you will see the paracortex. This is the expansion of paracortex, right? Hope you understand. Paracortex expanded with the infiltration by T cells, and these T cells, if you see, there is a peculiar ISC for this ALPS. That's why I choose this picture. These T cells, you know what? They will be positive for, they are negative, double negative, of course, that I told you, right? They will be positive for CD57 positive. CD57, right? And they will also be positive for CD45RA. Now, what is this CD45RA, right? To understand that, you know what, this CD45RA, yeah, I've written here, CD45RA, you know what, it is a marker of naive effector T cells. Now, in ALPS, of course, the naive T cells are persisting, right? That is why CD45RA is positive. Whereas when you talk about the mature T cells, like memory T cells, right, they are not formed here because, they are not predominant here at least. So CD45RO, which is a marker of memory cell, is negative. Right? Very confusing, but still given in WHO, that means it can be a question. Right? So the T cells here are CD3 positive. They are T cells. They are alpha beta type, which is obviously expected, but they are double negative. I mean CD4 negative and CD8 negative. As well as they are positive for CD45RA, whereas negative for CD45RO. Right? You remember like memory, something like that, OR, and you remember OR like that, whatever mnemonic, but remember this. It's CD45RO is a marker of memory cells, right? And it is negative in case of ALPS. As well as not just this double negativity, even they will have cytotoxic effector profile, not CD8. You see, cytotoxic doesn't mean they are CD8. They are not CD8, but they have porphyrin, they have TIA, they have CD57. These are all marker of cytotoxic T cell, right? NK cell and cytotoxic T cell. So these ALPS cells will have this marker, and because of this marker, they are having an autoimmune manifestation, right? Cytotoxicity will definitely manifest as autoimmune symptoms, right? So that's it in LPS. So next time anyone asks you, what are you going to see in LPS? Of course, flow cytometry if you are doing and getting more than 1.5% cutoff or more than 2.5% of CD3 T cells, right? Then that's the essential diagnostic criteria, and the ISS will be double negative T cells, CD45RA positive and CD45RO positive. As well as, you know what, another peculiar feature of ALPS is that vitamin B12, if you do now, that is increased. So many, it is increased, around 10 to 100 times fold, right? So why it is increased? And it's good now. You will think, hey, it is increased and it's good. Why are you bringing vitamin B12 for diagnosis of autoimmune lymphoproliferative syndrome? The reason is that in these T cells, there is a turnover there, and these T cells are known to produce hepatocorrin, right? Hepatocorrin, a transcobalamin like vitamin B12 binding protein, right? And because of this, the vitamin B12 is increased manifold because of this, right? And that can be used as a diagnostic criteria. Okay. See, and morphology wise, there are one thing is that in one fourth, what is this entity? You tell me. Is there any germinal center? No, na. Germinal center is atrophied, and there is proliferation of mental zone, isn't it? There is proliferation of mental zone. This is nothing but Castleman-like area, and 1/4 of ALPS can have Castleman-like area, right? Onion skinning and all, you can see that, right? Even it's a chunk of ALPS can have these histiocytes with emperipolysis, although not visible clearly in this power. Nothing like Rosai-Dorfman-like features. So ALPS can have Castleman-like feature. ALPS also can have Rosai-Dorfman-like feature. That you need to remember. So, but of course, the peripheral blood flow cytometry with double negative T cells is the clue, is the clinching point here, right? Of course, elevated B12 and all I already discussed. Okay, so